Hello, all. My name is Amy Vandenbroek. I'm the Executive Director for National POLST. Thank you for joining us today. This is being recorded. I'm excited to announce our first webinar of the year. We're hoping to do this on a monthly or every other month basis. And Chelsey is our first presenter of the year. Her speech is entitled, "The Devil is in the Details, a case-based argument for POLST registries." This webinar will make a case for the creation of advanced care planning registries by exploring the limitations of the electronic health record in capturing details related to both advanced directives and POLST. Dr. Chelsey Patten received her doctorate in bioethics from the, I'm going to mispronounce it, Neuswinger Institute for Bioethics at Loyola University Chicago, her master's in healthcare ethics from St. Joseph's University in Philadelphia, and her Bachelor's of Science in Molecular Biology from Chestnut Hill College in Philadelphia. Throughout her academic career, Chelsey focused on advanced care planning, end-of-life issues, and potential registry technology opportunities to improve access to advanced care planning documents at the end of life. Chelsey started with OSF Healthcare in October 2017 as an ethicist for St. Francis Medical Center and the Children's Hospital of Illinois. In her role, she provides ethics consultation services, education, and policy development and review. She is adjunct faculty at the University of Illinois College of Medicine and OSF St. Francis Medical Center College of Nursing. Chelsey also serves on the Illinois POLST Committee, is the director of the Illinois POLST Registry Subcommittee, and serves as a national POLST representative on the Technology Committee. So thank you, Chelsey, for presenting. I'm turning it over to you.
Awesome. Thanks, Amy. And good afternoon, everybody, and thanks for joining us. Like Amy said, I'm here to talk to you today about the devil being in the details around advanced care planning registries. So the things that I'd like to cover with you today are to review the benefit of advanced care planning and the unique role of POLST, to outline the current challenges of accessibility to POLST and other advanced care planning documents, to discuss the limitations of the electronic health record as it relates to POLST, to uncover how a registry may address the small details surrounding POLST compared to the electronic health record, and to summarize the overall benefits of an advanced care planning registry. So as we get started, I just wanted to make a few statements regarding my presentation today. So National POLST at this time does not have a stance on advanced care planning registries, but does endorse the creation and use of POLST registries. There's currently an ongoing technology consensus project through National POLST, which intends to identify helpful best practices and technology-related priorities, help align product development that supports the POLST paradigm, and to evaluate current systems and vendors integrating POLST with technology to help our state programs overcome some of the challenges that I'll address today. I'll frequently use the term advanced care planning throughout my presentation, which, as we know, is a process that helps ensure patient treatment preferences are documented, regularly updated, and respected. There are two types of documents that can be completed during the ACP process, and those are advanced directives and POLST forms, the latter of which will be my focus today as it pertains to registry technology. Both advanced directives and POLST are only as good as the conversation and the information shared prior to completing them, and POLST in particular should be a result of a shared decision-making process between a patient and their healthcare provider. I wanted to go over next just a few POLST-specific reminders that I would like you to keep in mind as I go through my presentation. First is that POLST is truly a decision-making process that results in medical orders. It's not just a check-the-box process in filling out a form. It's intended for patients who are considered to be at risk for life-threatening clinical events because they have a serious life-limiting medical condition, which could also include advanced frailty. A POLST has specific language about treatment options so it can be easily interpreted and followed. And as a medical order, POLST can be followed in times of crisis by EMS personnel in accordance with their protocols and by treating healthcare professionals, including physicians. POLST form review is encouraged when a patient is transferred from one care setting or care level to another. There is a substantial change in the patient's health status or the patient's goals of care change. A key tenet of the POLST program is that POLST forms must be easily modified or revoked to allow patients to change treatment decisions as their disease progresses. The POLST form is not meant to be a static document once completed, which is important to keep in mind as we go on. Let's just level set a little bit and talk about what do we know about advanced care planning. First, we know from numerous studies that have been done regarding advanced care planning that it leads to better quality end-of-life care by encouraging effective communication, decision-making, and transparent relationships with healthcare providers, leading to the completion of advanced directives, and subsequently the eventual completion of a POLST form when a patient is diagnosed with an advanced illness or frailty. We know that advanced care planning makes a difference in patient care. POLST in particular was found to change the medical treatment provided in 45% of cases, according to an Oregon-based study. We also know that providers want this information and expect that it will be reliable and available to them if it exists. One advanced care planning study found that 74% of ED physicians need access to advanced care planning documents at least once a week, and 43% of ED physicians need access at least 5 times per week. The benefits of advanced care planning are substantial. The key is accessibility of the documents that are associated with it. So what challenges do we have with advanced care planning and these documents? We know that advanced care planning is a positive thing, but unfortunately there's little proof that the preferences outlined in ACP documents are being successfully translated into action, which in part is attributed to the documents not being accessible when they're needed. We have family members of patients that come into the hospital all the time saying, I'm the power of attorney, but they don't have the document with them, and so we can't honor that. And the same thing goes for POLST forms. As I mentioned, POLST can have a significant impact in honoring patients' preferences. However, physicians still report difficulties with successful transfer of the document across care settings. We see a lot of patients who go back and forth from skilled nursing facilities to the inpatient setting. And we find that oftentimes they're transported from the skilled nursing facility to the hospital with no POLST, even though we may have one in the electronic medical record. When documents are present, providers still have a sense of uneasiness because without digging thoroughly through the chart, they're not confident that they're viewing the most up-to-date version of the documents. The previous example of a patient from a skilled nursing facility who comes into the hospital without a POLST, so we have one on file for them in their chart, leaves the providers wondering if the patient may have revoked the form while they were out of the hospital. And this leads to confusion and does not inspire confidence in the providers, especially when the POLST form that they have on file is directing them to withhold life-sustaining treatment. All of this leads to a gap where patients are receiving unwanted treatments at the end of their lives, despite their best attempts to record their preferences ahead of time. So health systems are spending a lot of money trying to improve their advanced care planning programs and trying to engage patients in this process to fulfill metrics that are being created for them. But are we doing the right thing asking people to take the time to fill these forms out and have these important conversations if we ourselves don't believe that the information will be accessible when it's needed most? The value of advanced care planning is significantly decreased if the documents associated with it are not there when we need them. I often hear from providers that they're concerned they're not viewing the most up-to-date form in emergency situations and would like to be a little bit more confident when accessing documents like POLST. I also often come across forms myself that are incomplete due to missing signatures or have incompatible orders such as CPR, comfort-focused treatment. Each of these points can impact patient safety. In fact, one study found that 37% of patients experience a medical error when their recorded preferences and documented orders were compared due to either incomplete documentation or inaccessibility of advanced care planning documents during emergencies. So why EHRs are not the answer? This is really the bulk of what I wanted to talk about today. One of the most common responses I hear when I talk about the exploration of state registries or national registries for POLST forms and other advanced care planning documents is that we have Epic or we have Cerner. Unfortunately, not all EHR systems talk to one another, and EMS doesn't have access to the same EHR that my hospital system uses, and neither do the skilled nursing facilities in our area. And I know that other hospital systems and providers have these same challenges. Where I'm located, we have another hospital that's directly across the street that we're not affiliated with, who also uses Epic, but that does not solve our problems. Because even if the patient is enrolled in Care Everywhere, which is a feature of Epic to access patient records from other institutions, we don't have access to their advanced directives. EHRs are not optimized to provide and reliably transfer advanced care planning information across the care continuum. Unfortunately, even when patients think they have given their advanced care planning documents to their primary care provider or to their hospital for safekeeping, they're often unable to be located. A study performed at an academic medical center in the southeastern United States found that only 13% of participants that had completed some sort of advanced care planning documents had any form of ACP documentation available in their medical record. Additionally, of participants who said that they had given a copy of their advanced care planning documentation to the hospital previously, only 31% were locatable in the electronic health record. And of the individuals whose primary care provider was also affiliated with the institution, only 19% had the correct code status listed or had advanced care planning documents available in the EHR. EHRs are not the answer to all of our problems when it comes to advanced care planning. In fact, they may be creating some of these challenges when it comes to these documents. Next, I'd like to share with you a real-world case study involving some challenges with POLST in particular and the electronic health record. So this case revolved around a gentleman who is in his mid-50s who has a history of acute chronic respiratory failure. He was having some trouble breathing at the skilled nursing facility where he resided, and he was sent to the emergency department for further evaluation. The physicians in the emergency department felt it would be appropriate that he be admitted to the ICU to monitor his respiratory distress. Upon admission, the patient is noted to have multiple POLST forms scanned into his chart. The most recently scanned states a DNR full treatment that was completed in early August of 2017, and so his code status was set to no CPR full treatment. For those of you who may not be very familiar with the POLST jargon, this means that if his heart stops, we're not going to resuscitate him, but we're going to do everything to prevent that from happening, including intubation. Once on the ICU, the patient's symptoms were managed with heated high-flow nasal cannula and BiPAP when needed, and everything seemed to be under control. But 2 days after his admission, the patient began to deteriorate, requiring intubation. Later in the day, the patient was somnolent but aroused for cares. But by the evening, the patient was awake and was pulling at the endotracheal tube, and he was physically restrained to protect him from removing the tube. Overnight, the bedside nurse noted that the patient was keenly alert and restless, and he was indicating to her that he wanted the ET tube out and the restraints off. When the nurse told him, "Your code status is DNR full, so you were intubated," the patient furiously shook his head no. When the nurse asked him, "Did you want to be intubated?" the patient again shook his head no. The next day, palliative care reviewed the patient's chart and found a more recent POLST form ordering DNR selective treatment, which was completed in late August of 2017, which means the patient never should have been intubated. So what happened? So this is a screenshot of this patient's chart, which Ethics was asked to do a retrospective review on, which is how I became involved. And so this particular screen, you're looking at the Advanced Directives tab within Epic, which houses all of our advanced care planning documents. So that would include powers of attorney, living will, any of our personal institutional documents related to advanced care planning, as well as POLST forms. So this patient has 12 POLST forms scanned into his chart, which is a lot. And the patient has only ever completed 4 POLST forms. So you can see that there's a number of duplicates that are in there. So the most recently completed POLST form you can see here in the purple highlight. And this is the form that states that the patient wishes to be DNR selective treatment, aka he doesn't want to be intubated. The next 6 forms that you see listed in green indicate that the patient would like to be intubated if necessary, but this is not the most recently signed form by the patient. However, it is the form that is believed to have arrived with the patient from the skilled nursing facility on October 7th. It wasn't until palliative care put 2 and 2 together and realized that the patient's demonstrated behaviors at the bedside and his current POLST form didn't match that someone started to dig into the chart. And what they found was the POLST form that I showed you in purple. So a family meeting was held with the patient and his power of attorney for health care, who ultimately consented to extubation and no re-intubation. And that's when the correct POLST form was re-scanned in, as you can see in blue. This does not seem like the best or the safest solution to me to make sure that we're capturing people's wishes and making sure that those documents are accessible in emergencies. So the question really is, are we doing the best that we can for our patients, or for that matter, to support our providers? So what went wrong in this case? I think it's safe to say that there were several factors that impacted the course of this patient's care during his stay. The first of which was the confusing institutional protocol that requires every advanced care planning document to be scanned in to the electronic health record when it's presented. That means that even though the patient is presenting with the same POLST form over multiple admissions, it still gets scanned into the record. So even when a patient presents it with a new document, such as a new POLST form, the old documents do not get marked as void. The next breakdown in the system was caused by human error, which we see fairly often. Each form that gets scanned in is supposed to be labeled by the type of form it is, followed by the date it was signed by the patient and or the provider. So if I myself was filling out a POLST form today, it would say POLST and then January 8th, 2020 in my chart. So as you can see, the DNR selective treatment form was not dated at all when it was originally scanned. And the POLST form for DNR full treatment, which wasn't even the most recent form, that was scanned in 6 times in a row, does not have a consistent date either. And then even the DNR selective treatment form that was scanned in again still wasn't labeled correctly after all of that. So another pitfall of the system is that there's no single source of truth for providers to rely on. So if they have a form that is coming in from the skilled nursing facility, but our form in the electronic medical record doesn't match up with that one, then it can get a little bit challenging. Another pitfall of the system it also seems like there was an opportunity here to talk with the patient when he was stable on the ICU. There really wasn't any documentation in the chart that the patient lacked decision-making capacity at this time, and no one readdressed code status with him despite this change in his condition or his inability to do so upon admission. Another challenge is that our EHR does not share advanced care planning documents with other facilities. There's really no way to validate that this is the most recent form without talking to the patient themselves. So it's pretty obvious that we have an opportunity to do better. We really need to do better to respect the wishes of our patients who have taken the time to consider their options and discern what aligns with their goals. We need to do better to help our physicians and our advanced practice providers honor the wishes of their patients and allow them to go through their healthcare journey the way that they thoughtfully intended. I believe that everyone that's participating today or viewing this later on wants to do better for our patients and providers, but may not have found a way to do that. And a registry could be one answer. So how does a registry help with the small details around POLST? I think first let's address what I mean by a registry. When I say registry, I'm not talking about just a repository for documents to live in. I'm thinking about something that is very technology-driven and has the capability to validate data, collect electronic signatures, and display real-time, up-to-date information about a document through a few clicks of a mouse. There are multiple vendors who are providing different technology solutions to whole states or healthcare systems today, which is helping to close some of these gaps. So back to the small details here. I think it's pretty fascinating that something as simple as labeling a document with the correct date can have such a significant impact on patient care. But as we saw with the case presentation, it really is the small details that get lost and set the wheels of error into motion. If this patient's POLST had been completed in a registry, let's say with electronic POLST completion, there would have been a date and a timestamp showing exactly when the signatures were collected. It wouldn't have been left up to the tech or the medical records staff to scan in and manually label the document. It's such a simple thing that's done now with lease agreements, taxes, and other forms, so I don't think we should be excluding POLST from this either. The next details that a registry could help address are the completeness and validity of a document. And as I mentioned, there are registry technology vendors working in this space that allow providers to complete POLST forms electronically. When a provider goes to fill out a POLST form, certain data points can be captured along the way to ensure that orders are being written logically and they make sense, and that the form has all of the required signatures prior to submission. In my role, I frequently review POLST forms. I have a stack about 75 in my office right now, and I often see forms with, like I said, incompatible orders or missing signatures. However, these documents still get scanned into the record and may be relied upon when the patient presents to the emergency department because people are just quickly trying to look at the data that's available to them. And this can obviously put both the provider and the patient at risk. The last small detail that I'll mention today is timeliness of completion. This is not one that gets brought up too often, but it certainly impacts patient care. If a registry can allow for electronic completion, signing, and sharing of a POLST form, it can rapidly cut down on the amount of time it takes to complete the document. In an ideal world, providers are having the conversation with the patient or their legal decision maker, a form is filled out, and it gets signed in the moment by both the patient and the provider. Unfortunately, in a busy acute care setting, this is not typically the case. A trained facilitator is often speaking with the patient about their goals for care and their disease progression, filling out the POLST form and having the patient sign it, and then leaving it in the patient's hard chart for the provider to sign. It's not uncommon that these conversations are left until just prior to discharge, and the provider does not have a chance to sign the form before they leave the hospital. The form eventually gets signed by the provider, and it gets scanned into the medical record. But how does that help the patient when they go home or back to their skilled nursing facility? It leaves them vulnerable to the interventions which they have expressed they do not want. And the ability to obtain an electronic signature from the provider could allow for more timely completion of these documents to help ensure that they leave with the appropriate forms to help inform emergency personnel of their treatment preferences. Something very similar happened to one of my colleagues who was a power of attorney for an elderly woman who came into the hospital just for a UTI. But there was a goals of care discussion while she was in the hospital, and they had decided that it would be appropriate to limit some interventions. And so they went through the process of filling out a POLST form with an advanced care planning facilitator. And then that facilitator left it for the provider to sign, but the provider didn't get to it before the patient discharged back to her skilled nursing facility. But luckily, my colleague works at the hospital and knows how these things work and knows to look for these things and look for POLST forms, so she knew the questions to ask. But the average person wouldn't know to check with their provider or wouldn't know to check with the skilled nursing facility to make sure that they receive that document. There are, of course, other benefits of an advanced care planning registry. I think the most important benefit of a registry is to ensure that we're honoring patients' expressed wishes. Next, a registry would also increase the amount of education around advanced care planning, leading to increased awareness. We wouldn't want to launch any type of registry without supplemental education because the two really go hand in hand. A registry also has the potential to improve accuracy and full completion of advanced care planning forms. One common issue I see in my work, as I've mentioned, is that I see a lot of unsigned forms, a lot of invalid orders, or even power of attorney forms that are incomplete. Some registry technologies, again, allow for that data validation piece where a form cannot even be submitted to the registry without valid orders or being fully completed. The most obvious benefit of a registry is, of course, increased accessibility to the documents themselves. So whether that's in a skilled nursing facility, in a patient's home through EMS, in the ED, in the hospital, many different care settings. And a registry can also lead to fewer unwanted in-hospital deaths if documents such as POLST are available in the field. A patient doesn't need to be taken to the hospital unnecessarily. And this, in turn, can lead to increased and lengthier hospice use. And one thing to mention that never hurts is a registry can help save health systems money. I want to make it very clear that I'm not endorsing a registry for the sole purpose of cost savings. However, someone who works for a large health system and works closely with administration, I know that the bottom line comes up in conversations about innovation. So will there be any type of return on investment for something such as a registry? So just to give savings a thought here, one study found that in their sample group of 325 patients who completed advanced care planning, that these patients had fewer inpatient admissions and inpatient days, leading to decreased utilization. This generated over $3 million in savings in Medicare expenditures when compared to the controlled group who didn't have any type of advanced care planning documentation. These savings could really prove to be significant given that 5% of Medicare beneficiaries who die in a year account for about 1/4 of that year's total Medicare spending. So to sum it all up, advanced care planning is a process that helps ensure patient treatment preferences are documented and honored through documents like POLST. Patients expect that their providers will have access to this information once it's completed, and providers expect that this information will be accurate and accessible to them when they need it. There are multiple challenges with accessibility and accuracy of advanced care planning documents that require the small details to be addressed, and the electronic health record is not equipped to do so. This inability to confidently store documents leads to patient safety issues, which are best addressed by registry technologies. So that is all I have. So if there are questions, I'd be happy to answer those.
And thank you very much, Chelsey.
I see your question, Carissa. She asked, is it common for providers to be left POLST forms to sign later? I would say in my experience, it is very common, but very frowned upon, obviously, from a POLST perspective. Always ideally, we would want our providers having that personal conversation with the patient one-on-one before they're signing any type of form. But I think that there are challenges on the inpatient setting that lead providers to be very limited with their time, and so that duty gets pushed off to our advanced care planning facilitators, and then the provider doubles back later to make sure that the form is signed before they're discharged.
And I'll just add, at the end of the day, the POLST form, as Chelsey pointed out, is a medical order, and whoever's signing it, the provider, their license is on the line. The expectation is that they are feeling comfortable because they are attesting to the fact that the orders match what the patient wants. So part of it is the team process and the trust in your team, but also just they need to be confident that the orders match. And as we've made clear, this is not an easy conversation sometimes. And there can be challenges in changing. So not a great practice to sign it later.
I would agree. All right. So like Catherine, the question, what is your funding source? How many resources are dedicated to the project? So within Illinois right now, we're just beginning the process of really talking about advanced care planning registry within the state. There are states that are doing it and are doing it very well, and the funding sources really vary depending on what the state setup is like. Oregon, for instance, I believe is funded by the state, whereas other states will have just purely donation that runs their registries. So it really depends. In the state of Illinois, we are one of the poorer states. So it's going to be a little bit challenging to get that funding from the state. So we'll probably have to look at some different options as we move forward. Okay, and then I'm seeing, go ahead.
Oh, I just want to make sure you saw the audience chat question from Paul Drager in New Hampshire. Does Illinois have a registry, and if so, who maintains it?
Yes, so again, not at this point, we don't. We are looking at exploring that a little bit deeper this year. We did have some legislation passed that calls for a feasibility study for a registry. So that's a positive move in the right direction. But as of right now, it's just a lot of fact-finding and digging to figure out what would work for the state.
I still need to meet with the conference committee, but for those of you who are on the line that are from a state participating in National POLST, we have a plenary assembly meeting coming up in April. So you would have at least 1 or 2 people from your state that would be invited to attend. Given that our registry map is rapidly becoming more and more purple, meaning that more and more states are actively working on registries, I expect that this will be one area of discussion, especially as the Technology Committee wraps up their white paper on best practices of integrating POLST with technology, including registries. So just something to keep your eye on, and hopefully an enticement to come in April. Looks like there's another question. What percentage of POLST forms are registered based on advanced directives from patients in your country? Thank you, from Spain.
You know, I'm not entirely sure how to answer that question. I don't think we have a very good handle of really how many POLST forms are completed in general, just speaking for Illinois, and versus how many advanced directives are completed. I think states that have a registry would be better apt to answer that question. I know that there is some data that's out there. And I don't know, Amy, if you know anything else about that. I know that there were some studies done and some data presented from other states. I don't know if you have any of that handy.
I don't, but I would also say that POLST forms aren't based on advanced directives necessarily. We always want to include the advanced directive if it exists into the conversation to make sure there isn't a conflict between the advanced directive and a POLST form, but a POLST form isn't pulled from an advanced directive just because an advanced directive really doesn't have the level of specificity. It's really based on the conversation. So while the two they complement each other and are related, they're separate to the process of completion. At least that's my approach towards it. So I'm sorry we don't have more detailed information for you.